Hi, everybody. My name is Josh Matthews, and I'm a fourth-year medical student at the University of Central Lancashire in the United Kingdom. So today, I'm presenting our case report, The Diagnostic Dilemma of Visual Hallucinations. So both formed and unformed visual hallucinations have been correlated to strokes of the occipital and temporal lobes. Isolated episodes of these hallucinations with no other focal deficits can cause diagnostic dilemmas. So today we present two cases of formed and unformed visual hallucinations, respectively, as post-stroke sequelae that were misdiagnosed. Our first case is a 64-year-old lady with diabetes, hypertension, hyperlipidemia, and a positive COVID screen that presented with severe headache and developed daily formed hallucinations 2 days later that persisted for 3 weeks. The patient presented to primary care complaining of bizarre images of people, crawling insects, spaceships, and flashing lights all over that raised the suspicion of a psychotic episode. However, she had otherwise intact documentation. Neurology was subsequently consulted, and an MRI showed an occipital lobe stroke. Occipital seizures were suspected, and levetiracetam was started with a good response. Our second case is a 63-year-old male with a prior significant cardiac history of endocarditis and prior prosthetic valvular replacement, and a previous left occipital lobe stroke that was treated by neurology with levetiracetam for occipital seizures. This patient was lost to follow-up, and levetiracetam was replaced with valproic acid for a suspected diagnosis of migrainous headache. The patient then presented to neurology 3 years later with almost daily episodes of unformed visual hallucinations, with confusion and headaches similar to his initial presentation. A neurological exam revealed right homonymous hemianopia with MRI evidence of left occipital gliosis. The patient was diagnosed with occipital seizures and was restarted on levetiracetam. So in both of these cases of occipital strokes, the correct diagnosis of post-stroke seizures with the proper management leads to the resolution of the symptoms of visual hallucinations. So in conclusion, isolated occipital seizures presenting with visual hallucinations can be misdiagnosed as either a psychotic or migrainous spell. Therefore, a detailed evaluation with a neurology referral is warranted for persistent episodes. Thank you very much.
Thank you. Are there any questions at this time? Can you describe a little bit about how neurology would typically work up these types of patients?
Sorry, could you repeat that?
Can you kind of describe how neurology resident would typically work up a patient like this? Like, what are some things that he or she would get in terms of labs, etc.?
Well, I think the most important thing is to make sure that a proper neurological exam is conducted and a thorough history of the symptoms as well. And then you can subsequently go on to do like imaging of the patient.